Hello everyone. Welcome to this webinar on acute MI in women. I am Dr. Lalitha, Assistant Professor in Cardiology from Nizam's Institute of Medical Sciences, Hyderabad. With me in this discussion is Dr. Jyotsna, Professor and HOU from Nizam Institute of Medical Sciences. Nizam's Institute of Medical Sciences is a deemed university, and caters to the cardiovascular needs of the patients and is a high volume center. Recently, the AHA has released scientific statement regarding all aspects of acute MI in women. Dr. Jyotsna, do you think we really require any specific guidelines regarding the treatment and outcome in acute MI in women?
Yeah, I think as we already know that there is a gender difference in acute MI presentations, management, and outcomes. I think we should have a separate guidelines. AHA scientific statement has come in the recently in this month, February 2016. Still, it is mentioned as a scientific statement, not as a guidelines. That means to say that we don't have the sufficient evidence to draw a guidelines. This statement is mainly depending on the two studies. One thing is exploring the biological contribution to the human health. Does the sex matters? That is the first one. And the second study is the women health research progress and pitfalls and promises. These two are published in the Institute of the Medicine. So I wanted to highlight once again that it is a statement but not a guideline.
Cardiovascular disease is the leading cause of death, be it men or women. Traditionally, coronary artery disease is considered a disease of the men, but it is evident from history that since decades, more women are living and dying with cardiovascular disease. There are few facts about the women CAD which has been highlighted by the AHA and quite alarming facts. In US itself, 6.6 million women are diagnosed with CHD annually. Of this, 2.7 million have a history of MI, 53,000 die of an MI, around 2 lakh women are hospitalized annually for an ACS. Within a year after an MI, more women than men will die of MI. Within 5 years after an MI, more women still die either because of the complications, heart failure, or stroke. If you see it 5 years or 10 years after an MI, the mortality is high for women unadjusted. The prevalence of diabetes mellitus, heart failure, hypertension, depression, and renal dysfunction are higher in women. Women more commonly present with NST elevation MI and non-obstructive CAD. Spontaneous coronary artery dissection and coronary artery spasm are more common in women. Women with ACS and those after coronary revascularization have longer days of hospitalizations, higher in-hospital mortality, and manifest more bleeding complications and more readmissions. Dr. Jyotsna, in this AHA statement, is there any role of the age and racial disparities being mentioned?
Yeah, actually, AHA statement itself starts with the influence of the age in the presentation of the acute MI. The women are often older when they are present with the first episode of acute MI, with an average age of 71 years, versus the men with the average age of 65 years. So the recent data shows that the CHD incidence and the deaths among the women between the 45 and the 54 years of age is increasing. The substantial decline in MI rates or the deaths in the United States in the past is documented, but this is not true in the case of the young women. This is demonstrated in the big study. There is, of course, there is a significant racial and ethnic variation between a broad spectrum throughout the world. But I wanted to concentrate mostly on the Asian Indians because we are the more concerned about those population. Asian Indian women have a greater proportion of the mortality burden from the CHD compared to the non-Hispanic white women. The hazard ratio is about 1.12 is to versus 1.0.9, and Asian Indians have a greater burden in the cardiovascular risk factors, particularly at a younger age. This is mainly demonstrated in the Interheart study.
What do you think about the pathology of AML? Is there any difference between the gender?
Yeah, of course. As we already know that an acute MI usually is associated with the thrombus formation in the culprit vessel. with underlying either the plaque rupture or the plaque erosion. The plaque rupture is seen only in the 55% of the women, whereas increased prevalence of the plaque erosion is seen in the women. But this is an autopsy series. Even in the OCT, there is a slight difference is demonstrated. In the initial studies are not able to demonstrate this distinction between the plaque rupture versus the plaque erosion, but the subsequent studies has demonstrated that probably the discrepancy between the autopsy series and the OCT is autopsy series also include the sudden cardiac death, where the plaque erosion may be much more frequent than this. And the second important thing in the women is the coronary artery spasm. The women with the coronary artery spasm are typically older. Actually, in the men, if at all coronary artery spasm occurs in the younger age group, and women had a lower incidence of smoking. Usually in the men, it is a higher incidence of smoking for the coronary artery spasm, and had a less significant obstructive coronary artery disease compared with the men who are presented with a coronary artery spasm. The third component, which is much more specific for the females, I should not say the specific, much more frequently occurs, is a spontaneous coronary artery dissection. As such, coronary artery dissection is a rare cause for the acute MI, but this incidence, this importance is increased, especially whenever there is increase in the incidence during the pregnancy. And nowadays it is demonstrated with other types of the vasculitis also. So we have to suspect a spontaneous coronary artery dissection whenever a young female comes with an acute MI with a restricted risk factors. This is demonstrated in the Mayo Clinical Series.
We know that smoking, hypertension, dyslipidemia, obesity, type 2 diabetes, and depression are the traditional risk factors for coronary artery disease. Does this differ in women when compared to men?
Yeah, as we already know, all these are the traditional risk factors. So both in the men and the women, both holds true. But there are certain risk factors like tobacco abuse, type 2 diabetes, and depression are more potent in women and have a stronger association with an MI, which is again demonstrated in the Interheart study. Suppose if you take the dyslipidemia, mainly in the form of increased total cholesterol level or increased LDL levels, this is predict the cardiac death in the woman. But the strength and the consistency of these relations in the older women are diminished. And another important factors are the decreased HDL levels and high triglyceride levels, which are the powerful risk factors for the coronary artery disease in the woman, which is demonstrated in the nurses' health study. Of course, obesity nowadays, not only in the Western, even in the Indian population, is becoming and gaining a much more an importance. And obesity is a major risk factor for the acute MI in women and increases their risk almost threefold. As we know that diabetes mellitus is a risk factor both in the men and the women. In the younger women, the diabetes is a more powerful risk factor and increases the risk of the coronary artery disease, including the ACS, by a 4 or 5-fold increase. The depression, even the general population, females are twice prone for the depression than the male members. In addition, this increases following the acute MI and causes the increases the incidence of the cardiac death because of the depression. This is demonstrated in the Virgo. This percentage increases as high as the 50% in the women.
Coming to the symptoms of acute MI, what are the most common heart attack signs in women?
Yeah, as we know it, any acute MI much more frequent presentation is the typical angina with prolonged, it's beyond 20 minutes. But this is not true or a classical presentation in all the women. Women often present with the atypical chest pains, and they will have some anginal equivalents like dyspnea, weakness, fatigue, and indigestion. This is the major drawback in the women. Because they present with varied manifestations, it is diagnosis becomes difficult, and the referral doctor doesn't diagnose it and doesn't refer to the proper center in appropriate time. This is demonstrated in the Genesis proxy study. Here, there is more likely to have the women are more likely to have a high risk presentations and less likely to be manifest a central chest pain. This is when compared to the men. But if you take the central chest pain as a presentation, that itself is common even in the women population also. If you take the sudden cardiac death as a presentation, the young female with a normal left ventricular function are likely to have the sudden cardiac deaths, and the women have a longer presentations and treatment longer times. This is, as we already discussed previously, because of either diagnosis is difficult or because of the change in the socio-economic factors also. Not only that, the median delay time is about 53.7 hours in the women, and it is about 15.6 hours in the men.
What about the treatment strategies and outcome following an acute MI in women? Does it differ?
Yes, of course. What we think is the guidelines and everything is the same for the men and women. So we expect that there should not be any outcome changes. But surprisingly, as we already know it with the previous studies, which is documented once again with the AHA scientific statement, that women are less frequently referred to the appropriate treatment during an acute MI, and women manifest the worst outcomes even though they come to the hospital. They have the worst outcomes because of an increased complication rates and increased bleeding risk in the woman. As such, MI itself is increased bleeding risk in the woman. In addition, with an antiplatelets and anticoagulants, the bleeding risk mounts up significantly. That's why in general, weight and renal dose adjustment is required in every patient, more so in the case of the female because they're more prone for the bleeding complications. And women have a favorable outcome with an PCI compared to the thrombolytic therapy if its presentation is an STMI, and benefit from an early invasive strategy in the stating in the state of NSTMI. So in the both the conditions, if we take a invasive strategy as a primary treatment and do the primary angioplasties, then the women are benefited much better. But that doesn't happen mainly because of the delay in the diagnosis as well as the referral. Women have increased in-hospital mortality if we take a CABG as a revascularization strategy as an initial stage.
I think the complications after MI are also high in women. Can you narrate what are the differences in the complications between the gender?
Yeah, as we already discussed about the bleeding complications, which are more frequent in the female, which is already demonstrated with the GRACE registry, and that's why the SAFE PCI is designed mainly to prevent the bleeding complication with the femoral side. They are choosing the radial side to see that when the complication comes down, really that study demonstrated improved mortality benefit by by doing the radial PCI. But still, even with the change of the route from the femoral to the radial, still the bleeding complication, the risk is more in the females. Not only the bleeding complication, the cardiogenic shock also. The MI women with the MI present more frequently with the cardiogenic shock than with the men. Surprisingly, despite of having a less extensive CAD and the coronary angiogram and a smaller infarct size, this area really requires some research on that. And so also heart failure is the more frequent in the women, and the mechanical complications. The acute mitral regurgitation is much more frequent in the women, and even the ventricular septal defect occurs more in the older women than in the men, and cardiac ruptures are also is more frequent in the women. Probably cardiac ruptures we can think of more frequent in the women mainly because of the delayed presentation and the delayed thrombolysis. So that may partially can explain that complication.
Do we have any studies which have shown or what are the prognostic factors for adverse outcome in women? Because all the previous studies they are always underrepresented with women.
Yeah, that is true. Even the scientific statement has come because of the underrepresentation. It is not like a guideline, but still there are the few parameters like severity of the coronary artery disease extent, the type of the presentation. Suppose if you take the person who presents with the chest pain, likely to have a better prognosis, especially in the women when they have an absence of the chest pain as a presenting symptom, they have the bad prognostic factor. Of course, presenting as an STMI and presence as a diabetes itself is a bad prognostic factor both in men and women, more so in the case of the women. And other one is other burden of the woman is the psychosocial factors, especially in the young females. They have the burden of the marital status also. So we have to concentrate more on the psychological stability of females much more so than in the male. We talked about the so many variations occurred in the women when compared to the men. Do you think that our knowledge is sufficient enough to say that all the defects or all the differences between the men and women can be explained? Is there any gap?
Unfortunately, despite all this extensive literature that is available, there are still many gaps in the knowledge of acute MI in women. We are not sure about the biological, pathophysiological, and psychosocial risk factors among women regarding the CHD development and progression. We don't know still why young women with VACS have a mortality disadvantage over young men with ACS. We are not sure which is the most effective intervention for decreasing all these treatment delays. We are not sure still of the most effective strategies to reduce the mechanical complications. How do we modify the psychosocial factors? And what are the most effective interventions to improve the cardiovascular health behavior among women? What are the modifiable factors contributing to all these sex disparities when we apply the evidence based guidelines in the prevention and treatment of women with CHD?
Yeah, what you are told is the gaps in knowledge is true, but is there any discussion of or any suggestions given by the scientific committee for that?
Yeah, definitely. AHA scientific committee has given priority to certain issues in women which we have to implement. The first among them is to increase the awareness among the women, the entire public, the healthcare providers, and the policymakers. We need to improve the methods to diagnose and treatment CHD. We have to increase the treatment rates for secondary prevention. We have to emphasize on adherence to guidelines both by the clinician as well as the patient. We need to develop more effective primary and secondary prevention behavior interventions that are culturally appropriate for women. And last but not the least, more and more women have to be included in the research which is concerned in the cardiovascular clinical research group. Dr. Jyotsna, all this statement given by the AHA, how much is it apt to the Indian scenario? Do we have enough evidence for that?
Yeah. Most of the time, we had to depend upon the Western literature to know about the pathophysiology, management, or the prognosis. I think this is a high time for us to concentrate on the Indian scenarios to know about it. But as you already know it, the representation of the women in the research side, especially the design studies, are the less. But still, I think there is a little bit of evidence we have it from the already established data, like from the Interheart study, data from the Center for Disease Control and the Prevention, CREATE registry, DMAT registry, and Kerala ACS registry. Of course, there are the about nearly 9 to 10 small single center published studies are available. I think if we analyze them a little bit more, probably we know that in the Indian scenario is that is different from the Western scenario, or can we take the same scientific statements applicable to the our Indian situation, or should we have the more data or more information to apply to the our Indian situation? Suppose if you take the Interheart study, which is a quite old study, which is published in the 2004, but still it is relevant because it is demonstrated till the 2000 there is an increase occurring in the incidence of the coronary artery disease in women from the 1984 to the 2000, and then there is slight decrease, and recently there is a 1.5% increase in the western population. So still, even though it is 204, because it's a large cohort study, nearly including 12,000 cases and 14,000 controls from the across the 52 countries, including the majority of them from the India, I think it is an appropriately applicable about the Interheart study with us. If you the major risk factors are mentioned in the Interheart study are about the current smoking, diabetes, hypertension, abdominal obesity, psychological index, consumption of the fruits and vegetables, exercise, alcohol, ApoB, ApoA1 ratio. If you see the psychological and psychosocial factors in the females are the much more than in the males. Of course, this ratio then ApoB and ApoA1 is also more, but this is variation is slightly less. So we can consider it as ApoB, ApoA1 ratio is applicable for the Asian, both women and men, and the psychosocial factors are much more in the females.
The key results of the South Asian component of the Interheart study are: death due to AMI occurred at 5 to 10 years earlier than the Western population. Men encountering AMI were 5 to 6 years younger than women. The Interheart study focused on 9 conventional risk factors, which could explain 86% of the AMI risk in the young. Among them, smoking and abnormal ApoB1 B by A1 are the most important risk factors. High waist hip ratio was also defined as one. Protective lifestyle factors such as leisure time physical activity and regular intake and fruits of vegetables was lacking. High level of risk factors were seen in both cases as well as controls under the age of 60. A regular alcohol consumption, which was proved to be cardioprotective in the West, is not so in the South Asians. Though the Interheart study was not designed to find the gender differences, it came to a conclusion that in young women, if 5 traditional risk factors, that is smoking, diabetes, hypertension, hyperlipidemia, and BMI, are under control, then CHD is a very rare event. Unfortunately, this control of the traditional risk factor is seen in less than 20% of our population.
I think the slight change in this alcoholic effect from the Western to the Indian population probably can be explained by the variation in the incidence of alcoholic consumption. Alcoholic consumption is slightly the less in the Indian population when compared to the West. But the thing is, once they started consuming, they consume in the larger amounts. That is one of the explanations given in the Interheart study why it is not able to prove the efficiency in the Indian scenario.
Unfortunately, there are still some questions which are unanswered in the Interheart study. Why do Indians have a high level of risk factors at a young age? Despite the low level of risk factors, why still CHD or diabetes occurs in young people? Is there an effect of the gene environment? Is there any role of macro or micronutrients in the Indian diet? Does the pattern of migration influence the risk? If so, what are the potential interventions we can take to reduce the risk? Hopefully, the upcoming study, that is the PURE study, which involves 28,500 people from 5 different localities in India, might provide us insight into the cause of obesity, diabetes, and CVD risk factors in South Asia, which we can attribute to urbanization. What do you think is the scenario of ACS in women?
Yeah, actually, some of the studies are mainly concentrating on acute coronary syndromes than acute myocardial infarction subgroup of an ACS in the woman. And there are the few small single center studies are there. As we already mentioned, we talked about the little bit bigger studies like an Interheart study. Some of the studies like the Sahin, Rohit Kumar et al. And Mistria and Nagamalesh, Zaisi, all these studies are concentrating on the type of presentation, outcomes, time in the delay of the presentation. Even though there are the small in number, but because there are published ones and comparability, probably we can apply along with the Western population and we can come to a fairly reasonable conclusion. I can't say conclusion, maybe a reasonable idea that whether it is an Indian scenario, acute MI in a woman is different from the Western literature. So if you compare them, of course, Zai B et al. Studies in young women, so we can't take the age group 44 as a usual age group. That is, they considered in young females itself. So usually the Rohit and Mishra et al. They demonstrated that it is varies between the 62 to the 69 years, almost the same as that of the Western literature. And the diabetes actually in as such in the women, diabetes, hypertension, and are the slightly more, but are not looking like a grossly different from the Western population. But if you take in young females, it's gross difference is there. You see that 63.6% of the diabetics and hypertensive patients in young females are having an important risk factor. So that is pounding a much for the acute MI development for them. Of course, the dyslipidemia also almost 82%. It is quite high. Of course, current smoker or ex-smokers incidence is quite less here. Probably this may be underrepresentation. As such, the smoking practices in the Indian people are slightly less than Western, but still it is quite significantly high. It is fact that it is not represented in a complete correct way.
Well, it is said that men are from Mars and women are from Venus. Does this hold true when it comes to the presentation in MI? That, in other words, does chest pain present the same in men and women?
Yeah, as we already talked in the scientific session, the atypical presentation is more frequent in the females. So let us see what happens in our Indian
Indian.
population also. So the two major publications where they talk about the type of the presentation is from the Nagamaleshan et al. And Sahin et al. And here they told about the type of presentation as chest pain as the initial symptom is 93, whereas Sahin et al. Specifically classified them as a typical presentation in 69% of the patients and atypical in the 25. So, but this is not the comparative study between the men and women to say that whether the atypical presentation is more frequent or women. But the way it is presenting, nearly one-fourth of the patients are coming with an atypical presentation, says that it is a little bit unlikely. Acute MI almost for public awareness is a chest pain, almost similar to the chest pain. So one-fourth are not having a chest pain is an important information from this study. Of course, 6.25% has a dyspnea and 10% has an presyncope and 25% has a nausea or vomiting. 13% has an about diaphoresis. And if you classify the TIMI risk scores, it comes as a 56.8% of the cases comes under the TIMI risk score of lower grade, whereas the rest of them means 43.5% will come as an intermediate high risk. The one important feature is most of the women, nearly 95%, will experience a prodromal symptoms more than 1 month. According to the one study, it is as early as 6 months is known to occur. But the major problem is, even though we have such a significant prodromal symptoms, because of the atypical nature of presentation, we are underdiagnosing. We all this time we are talking about the presentation, detection, referral, but what do you think once the patient comes to the hospital, is there any difference in the treatment managements in the Indian scenario?
Well, the two basic modalities of treatment in acute MI, one is thrombolysis, second one is a mechanical perfusion,
Do you think the
possibly
thrombolysis should be
angioplasty.
talked now because the PCA is approved beyond doubt?
But there are many scenarios in India where thrombolysis is the preference. Many of
That's
our patients do not have access to the PCA.
that's
So in our country, definitely even now, thrombolysis has a major role. Coming to the studies which are available on this reperfusion theory, especially in the real world scenario, if we see from 2004, the earliest study was in 2004 by Gupta, followed by Create study in 2008, and later by Kunwa in 2012. There are many other small studies, but these are worth mention because if you see there is a decade difference between Gupta study and Kunwa study. But what was common in all the three studies were that women were constantly underrepresented. If you see, the representation is not more than 20%, rather it is less than 20% in all three studies.
actually uh, according to the guidelines 30% of the female population representation is required,
Yes.
is a mandatory.
Yes. And these studies also highlighted the fact that less women receive the appropriate guideline required treatment. If you see the patients who underwent PCI for ST elevation MI, less than 10% were women in all the three studies. Even in thrombolysis, where we expect the rates to be high, it was only 12% of the total patients who required thrombolysis that they were women. But this is possibly a bit old story. If we come to the recent trials, which are more encouraging, of them it is the Sahani et al. And Misiria and Kunwal, who had studied the thrombolytic therapy in acute MI in women, and Nagamalesh and Nanjappa, who had done it in primary PCI. And they showed that the incidence of thrombolytic therapy in women was 32% at Sahani and around 58% according to Miss Tia. However, a majority of the patients could not receive thrombolytic therapy because they presented late. The other two studies, which were on angioplasty, that was by the Nagmalesh and Nanjappa, they showed a very favorable response when it comes to primary PCI in women. In fact, Nanjappa et al. Has shown that the incidence of primary PCI in women was 68%. If we leave the old studies and come to the new studies, the DMAT study, which was done by GMON, which showed the association between the gender, the process of care, and outcome in SS, that is from the DMAT registry, it was quite encouraging and was very surprising, which we are not able to believe. These studies showed that if the age and other traditional risk factors were neutralized, then there was no difference in the in-hospital management between women and men. In fact, all the men and women equally received the treatment for acute MI. There was no difference in the use of statins, beta blockers, or antiplatelets. There was no difference in the reperfusion strategy, whether it is PCI or CABG.
It's really a surprise. Even in the Western population, it is mentioned that the PCI referral itself is less, and once it is referred, it is going to have an effective PCI. But this study is really changed the idea. Probably is that improvement in the strategies and improvement in awareness is responsible.
I think it's so. Because this only tells the fact that the awareness about cardiovascular disease has increased in our society. Whether we need to believe it or not requires further studies and trials. There are not many studies on the angiographic profile in women. There were only two studies, the Zeiss EB, which has studied in India as well as the Singapore population, and the study by Nagamalesh, which showed that single vessel disease was most common in women, and even among the single vessel, it is the LAD involvement. However, they have not studied any gender differences, whether some other vessel is common in the male or so. And there was only one study by Miss Ria which is concentrated on the door to balloon, rather the symptom to balloon time. And they showed that the symptom to balloon time was quite prolonged, around 320 minutes in India.
But do you think even that is a 320 is okay, or usually in our experience we think it is much more than that?
I think in our real world scenario, definitely the symptom to balloon time is more prolonged. And one study by Sahani has focused on this fact also. And they showed that 55% of the patients who present late for the appropriate treatment is because of the delay in presentation from the first physician to the cardiologist.
Oh, it's not only the patient coming. Even after the patient comes, the referral from the physician to the appropriate intervention site is also is delayed.
And the rest of the 45% is either because they're staying quite far away from a hospital or they're not able to come here because of the financial constraints. This was all a talk about the PCI and thrombolysis. What do you think about the CABG profile in our Indian women?
Yeah, the major problem what we face in Indian women is body stature, decreased body mass and index. There is one study already demonstrated that LAD diameter in Indian population is going to be 1.28 millimeters. But for a surgeon to graft also at least more than 2 millimeters is required. So it may be very difficult for them. The smaller size of the women's coronary arteries may be contributing to their higher operative mortality and poorer outcomes in the following the CABG. But as we already talked, according to the guidelines, the CABG as a primary reperfusion strategy is required, like in a subgroup of diseases. Then women does worse than that of the men. If you talk about the mortality in the women, even the mortality rates after the acute MI are the more in the case of the women. Can you highlight on that?
Well, Definitely, global evidence is that women have a high mortality rate after acute MI, and the same holds good even in India. These results are from single center studies. However, if you see the Indian census also, it is seen that the majority of the deaths in India are because of cardiovascular deaths. If you come to the single center studies which are focused on acute MI, the most prominent among them is a study from Mahatma Gandhi Medical College, Pondicherry by Rajendran, which has showed that the mortality rate after acute MI is around 8%, and among female, this amounts to around 21%. Even Sahani et al. Presented a paper on the complications after acute MI. It included a study on the in-hospital outcome as well as the outcome after 1 month. And they showed that the death was around 13%, the incidence of heart failure was around 35%, and arrhythmias were around 8%. Even 1 month after the presentation, the incidence of death was around 5%, and in reinfarction was seen in around 4%.
I think we have a good comparison between the Western series and Indian scenarios with the limited data then available. So I think we have to improve on that. So do you wanted to say any conclusions out of it? Do you wanted to give any suggestions out of these in acute MI presentations in women?
Actually, these conclusions which I am presenting are from the AHA. So let us come to that before we come to our own conclusions. So AHA has concluded that cardiovascular disease is an equal opportunity killer, and since the past 3 decades, the mortality burden has been higher in women. It is only in the last 1 decade that the mortality in women has come down. However, this does not hold true for the young female with MI. This dramatic decline in the mortality rate could be the result of the application of evidence based therapies and education to improve the public and the medical community's awareness of heart disease. Definitely, this is encouraging. But there remains an excess mortality in women that is multifactorial, which we are not able to modify. There have been sex differences which occur in the pathophysiology and clinical presentation of MI and affect the treatment delays. Recommended perfusion therapies in acute MI are definitely the same as in men, but complications and bleeding risk are greater in women. Women are undertreated with guideline based recommendations. This leads to worse outcome and increased rates of readmission, reinfarction, and death in the first year after AMI. There is definitely a need for continued public health messages and intervention. We require a multidisciplinary research team which can work on innovative secondary prevention models that will cater to women which are age appropriate, culturally sensitive, and are personalized to women's psychological and physiological characteristics.
I think the two important things out of this discussion I'm able to make it out is one thing is increased awareness in the public and the doctors. Both are required. We think that as a doctor, they already know about the disease, but the evolution of the disease is in a variable from the basal normal presentation. That distinction has to be highlighted to the physicians and including the cardiologist. I tell my own experience actually in the initial stages when before I started thinking about these women heart diseases before the 2007, even I used to send off the female patients when they come with an atypical chest pain, not to further investigate it also. So that is a usual tendency. But when I started seeing that all the studies are demonstrating with an increasing incidence, which is actually proved in the 1984, but it took such a long time for us to realize it. And retrospectively, we are analyzing and saying that it is started increasing from the 1984, but actually it is not there in our idea. And whenever we are making the ICU rounds, we used to comment that we have to see a one day that probably whole of the ICU with the female patients. We used to comment like that. Then we realized that it is not just a comment. Then really increasing incidence is occurring. Like we are seeing increase in incidence of the heart failure. This is perceived much more earlier, much better than the women heart disease in the older age, in the past. That is a major thing. And the second one is a psychological burden. Even though the degree, actually the females are not very well preserved at the time of the acute MI presentation. Actually, that is one of the determinant factors to have an subsequent improvement or recovery from the acute MI stage, which is not there at the time of the presentation itself with an acute MI with the females. So the one is the physical factors are then very much decreasing, and as well as the psychological then effects. In general, they have the more psychological abnormalities than the men. As I already mentioned, is twice the more frequent in the general population than in this population. I think we have to concentrate on the secondary preventive counseling centers after the acute MI. Actually, ACC guidelines, which we are not touched much, is the counseling. Given an importance to that. So I thought it is better to bring the topic also once here.
Especially cardiac rehabilitation and then sexual counseling for women, especially after an MI. These are two important issues which have to be stressed, and you require a completely different section to deal with it.
Yeah. And another thing, what I think is the representation. Even though theoretically we are talking that 30% representation is a mandatory for a study approval, but still it is not come into as a guideline or a mandatory thing. Especially in the Indian scenario, it is not there. And most of our the studies are the retrospective analysis of the studies than prospectively recruiting and seeing it. There is a slight risk of prospective studies randomization into the different strategies. Once it is approved, PCA is approved value, you can't say the medical therapy. There, I accept comparison between the observation study of thrombolytic therapy or medical management versus the PCAs and applied true. But we require a planned study for the improvement of PCA therapies in them.
Dr. Jyotsna, before we end this session, would you like to convey anything specifically to our viewers?
Yeah, I think we should have the first thing is we will increase the awareness in the public by doing the conferences uh, and the communication directly or
In
through the,
other words, we will try to implement what AHA has said
yes,
by including more women in our studies and
yeah,
increasing the awareness among women, public, and the healthcare.
that's true, excellent. So, but one more thing is it is not a problem on the only women doctors. 40% of the women patients are treated by the male cardiologists and general physicians. So everyone has to be keep their hands help with the associations and everything. So I think I welcome all the people to come to our the WCC program, which is going to be on the March 8th. That is on the eve of the International Women's Day in Nizam's Institute of Medical Sciences. And we can go through our website of INCARS association.com, including all the latest improvements in the women heart diseases, including the presentations, interesting cases, everything. We are waiting for your the contribution, mainly by the presence and representation. Thank you all.
Thank you.